All right, welcome to this evening's webinar. Thanks everyone for taking time out of their schedules to be here with us online. I'm speaking to you all from Tulsa, Oklahoma, where I practice periodontics in private practice here in the middle of the country. At any rate, I've got what I hope to be an interesting topic to everybody today. It's called correcting gingival recession with acellular dermal grafts and other materials. I want to say right off the bat, it's the majority of our time is going to be spent talking about acellular dermal grafts, and for reasons that I'll reveal very soon. I always like to start off my presentations with this quote. It's amazing what you can accomplish when you don't care who gets the credit. Benjamin Franklin said that, and I always start off this way because as you go through this presentation today, I don't want to take credit for anything that I've done. Uh, I'm only here because of all the other clinicians and researchers that have come before me. So everything's borrowed knowledge, and I really owe it to everybody who's kind of set the bar high for me. The reason why we're here today is there's a lot of talk about pink and white aesthetics today. When it comes to periodontics and periodontal surgery and how it relates to restorative dentistry. And I really want to know, as we go through these first couple of slides, what would you all do in these situations? If you're a periodontist or restorative dentist, what would you have your patient do? I mean, would you put class 5, composites in all these defects? And there's numerous defects here. What about in this situation where we have recession on random teeth, on every other tooth, as opposed to generalized like the case that I just showed you? Or what about here? This patient's wanting veneers. Do you just restore the teeth as they are, or do we take that a step further and correct the pink aesthetics before proceeding? Here's another situation similar to the last one. What about here? And what about here? This patient, unfortunately, has already been provisionalized, and the reason that she came to our office was because she wanted something more. What is it that we can offer her today with today's technology and advancements? This lady is similar. She has an old fixed partial denture, and she's seeking a better looking smile. What can we offer her today? So the question is what's available for patients. When I graduated, from my periodontal residency in 2002, and I can say, after graduation, I had probably tried an acellular dermal graft once in my 3 years of residency, and honestly, I wasn't very confident in it. But I soon grew to understand that there was a technique, there were some tricks of the trade, so to speak, in getting these acellular dermal grafts to work. But I soon realized that this, using autogenous grafts, while I still use them plenty today, and they still have their place in periodontics and restorative dentistry, we do have other things to offer. There's a great deal of difference between a dentist with 10 years experience and one who has repeated the first year 10 times. I truly believe this coming out of school because, if I feel that, 10 years later, if we're still cutting tissue out of the patient's palate and not having another alternative for patients, I think we're going to be in deep trouble. Just not only for patients, but dentistry in general. I never want to limit myself to one technique. But with soft tissue grafts, I just want to show you some of the after effects of some of those cases I just showed you. This is 4 years later, before and after of that anterior aesthetic case I just showed you. This one's at 2.5 years, and all we did here was we only treated this lady's upper arch for now, and part 2 of her case is going to be the lower arch. This case I showed you after correcting the pink aesthetics. She's now ready to proceed with her restorations. And then we treated this woman's upper arch, and there's a before and after. Just another case here, and then finally I want to show you a couple of restorative cases that we've performed here. So just by giving a patient more alternatives to correcting the pink aesthetics and establishing a more ideal gingival contour for them, it empowers them and gives them the ability to accept, more comprehensive dental care because they can see the light at the end of the tunnel. They can see the end, the end in sight. What about this case where we had the excessively long retainer on the lateral incisor, where it's about 3 millimeters longer than the plonic and even the other central incisor? With acellular dermal grafts, we can easily, in one visit, often an hour or less, give this patient what she wants rather than what she needs. So for patients, soft tissue allografts can be a game changer, but they're not just a game changer for patients. They're a game changer for periodontists. They're a game changer for restorative dentists. When we're not married to the architecture that they give us, we can actually, take more pride in what we're doing, and in turn, patients are much more appreciative of the work that dentistry can offer them. But before we get into that, let's talk about, some of the classic techniques. Here in Tulsa, Oklahoma, I can tell you that, the most common treatment for recession, unofficially to me, is the Class 5 composite. And anymore, I would say, unless patients are bound financially, or for some other reason, Class 5 composites are kind of going the way of the dinosaur. Connective tissue grafts are still very common, and below this, there's a number of other techniques that we could talk about as well, which we don't have time today to discuss. But the newer techniques that are out there in the literature are going to be things like the acellular dermal grafts, which we'll spend most of our time talking about today. Things like perioderm, alloderm, dermis. But bone replacement grafts are also becoming, are starting to emerge as ways to cover recession defects as well. Of course, the enamel matrix derivative, Emdogain, in other words, has been studied extensively as well. But there are several other products on the market that I wanted to mention that are in the literature. But because the connective tissue graft is the most common, and it's what most people are familiar with, I just wanted to touch base on how that happens. Here's just a real quick example of Class 2 recession on number 22 through 26. You can also see that the keratinized tissue is relatively thin here, and we have a relatively high mandibular midline frenum attachment. All we do in this situation is I like to harvest all my connective tissue grafts through a parallel incision in the anterior or mid palate. That's what our graft looks like after it's been harvested. That's what the donor site looks like. And I always secure my connective tissue grafts around the teeth with just sling sutures. That seems to work well for me. And then we coronally advance the tissue as much as possible without putting the flap under tension. And here we've sutured it with some sling sutures as well. The final result, as you can see here, is that we've got complete root coverage, and we've also increased the thickness of the keratinized and attached gingiva, and at least adequately responded to the high frenum attachment. The advantages of the connective tissue graft are fairly obvious. You can get plenty of predictable root coverage. It has the longevity, the staying power that we're looking for. I believe that when Langer and Langer first introduced the technique in 1985, it's been a very common technique and does stand the test of time. I put a question mark under whether or not it increases the keratinized and attached gingiva, because it all depends on how you suture it. If you leave the connective tissue graft exposed upon suturing, which you can do, you'll get an increase in keratinized tissue. However, if you cover it, then you don't. But the big disadvantages of it are also obvious. You need 2 surgical sites, which means more pain and discomfort for patients. Because of limited anatomy, limited amount of available tissue, that could increase your chair time for both the doctor and the patient. It also increases the number of visits. So this cuts into, what is the risk and the reward for patients? Are we pleasing them, or are we pleasing ourselves? Of course, there are some other anatomical variations as well, such as unexpected palatal tori or tubercles. And also, let's not forget, when you're going to the roof of the mouth, there are varying tissue qualities there as well. Just an example of what a palatal tubercle looks like. We're looking right here, just lingual to the premolar. You can actually see a pretty large tubercle here. This will impede your ability to harvest the type of tissue that you want. And also, I started off with this slide, that your tissue can either be very fatty, very glandular, or just perfect. So you never know when you go to the palate, exactly what type of tissue you're going to get. So why would you ever do a palatal graft? Because you can leave the connective tissue graft exposed, to the oral cavity. You don't have to cover it with tissue. It's great for color matching. Let me just go over a real quick example for you. This lady has a bridge from number 8 to 10, and she has a horrendous-looking amalgam tattoo here that she wanted corrected. Now, having about 8 or 9 years of experience with acellular dermal grafts, I can't say that I've I haven't developed a technique that can adequately correct a amalgam tattoo. However, with connective tissue grafts, it's very predictable. Here we prepared our recipient bed here with just a partial thickness flap. Harvest our graft from the roof of the mouth. And then here, all we've done is I've just used some chromic gut sutures just to tack it into place. Here we've just used 4 interrupted sutures. Because of how well autogenous grafts from the palate take, here there's really a low risk of failure here, and this is our final result. Here you can tell that we have a much greater thickness of tissue. The tissue blends in with the surrounding tissues as well. The ponic also looks like it emerges from the tissue, whereas before it really didn't. Let me show you before and after here. So there's our before, and of course here's our after. So with connective tissue grafts, once again, I don't suggest that we just get rid of the palatal graft entirely, but I do want everybody to understand that amazing things can be accomplished with allografts as well. But let's talk about this. First allograft I want to talk about, because it's the most widely studied, is alloderm. Alloderm is basically a human processed tissue. It's a very safe product to use. It's got a long history in medicine to treat burn victims. It's also used in plastic surgery. As far as in periodontics, we've been using it to correct gingival recession defects for a couple decades now. There's plenty of references. This is just a very short and not at all intended to be a comprehensive list of references here. But how I like to do it, let's talk about the flap design. When we're talking about alloderm in particular, a very common flap design is a tunnel technique or an envelope, type flap design. I'll tell you right now, the flap design I'm going to share with you is just a traditional variation of the coronally advanced flap, utilizing vertical incisions. This sounds a little crazy to some people, but as we go through our presentation today, I'll show you that how predictable it can be. Just a short illustration of how I designed my coronally advanced flap. Like I said, it's a small variation on how it's classically done. But if you ignore all the numbers and algebraic symbols here, it's all we're really doing here is designing a flap that can adequately cover a recession defect without placing tension on the flap. That's kind of the key thing here, is if you can suture your flap well, then your aesthetic result and patient comfort will be just fine. So let's go through an example with teeth numbers 27 and 28. What we're looking for here is we're trying to cover 4 millimeters of recession on number 27 and about 3 millimeters of recession on number 28. My first step here is I just use a periodontal probe, and I'll make a few bleeding points, at a point apical to the tip of the papilla that's equal to or greater than the length of the recession. So as an example, the recession on number 27 is 4 millimeters, so I'll go 4 to 5 millimeters apical to the tip of the papilla and make a bleeding point here. And then I do the same thing with the other areas surrounding the other tooth. Next thing I'll do is I'll drop 2 vertical incisions, one distal to number 28, the other one mesial to number 27. And then all I do is I just merely connect the dots through the facial sulcus of the teeth. In our next part of the procedure here, which is a little bit different than traditional periodontal flaps, I'll actually go, reflect a full thickness flap to expose the first 3 to 4 millimeters of the bony crest. Immediately you can see the extent of these dehiscences that are present. The next step is to just deepithelialize the papilla. I usually use a number 4 or a number 2 round diamond to do this. The rationale behind that is that you can't put connective tissue on top of the epithelium and expect it to attach. So you have to place connective tissue on connective tissue. Here, what I've done, I've overexposed this photograph to show you the root, what we do to the root here. The only thing I do is I'll just plane the root with either a round burr rotary instrument or hand instruments. You can kind of see that the idea here is to come up with a flat root surface for the graft to adhere to. What I'm doing here with the blade is I'm directing a 15 blade just towards the connective tissue side of the flap to score the periosteum. As far as what I do to the root as well, it's a question that always comes up, is how we treat it. There's a number of ways you can treat the root surface. I prefer just a clean root surface with either rotary or hand instruments, but there's a number of other suggestions out there, such as using a tetracycline pumice. You can etch the root surface with EDTA gel or prep gel or citric acid. So there's a number of ways to do this, but I prefer not using any chemicals. I just use use hand instruments or rotary instruments. And here you can see that what that incision in the periosteum looks like. What that does is it enables me to passively advance the flap. Here you can see I've got it almost to the cusp tips of the teeth using just a Pritchard elevator. But it's important to me that the flap is very passive. Obviously in the premolar site you want to be aware of your anatomy and not sever any vital nerves. As far as the suturing goes, I like things to be as practical as possible. So we'll talk about suturing, but really the only thing I use is 5/0 Vicryl suture and utilizing sling sutures. The thing with Alloderm and other materials similar to this is you do have to hydrate them. So for Alloderm, as far as their packaging instructions, you have to do 2 hydrations. The first one is just for 5 minutes. The second rehydration can be up to 40 minutes if you're using the thicker version of the Alloderm. That's the other thing too, is that most acellular dermal grafts will come in either two thicknesses, one thin and one thick. As far as my suturing technique, I just use 5/0 Vicryl, as I mentioned. Now I just use sling sutures to adequately secure the graft to the root surfaces. Now, other alternatives, you can use interrupted sutures if you wanted to. There's a variety of different ways to suture it. And then I'll advance our primary flap and secure the coronal parts of it also with sling sutures. Here I've used 5/0 monocryl. The reason I did 2 different types of suture here is just so at our 2-week post-operative appointment, when we remove the sutures, I'll know which ones to take out. The vertical incisions are simply closed with continuous sutures using 5/0 Vicryl sutures. Sorry about the fuzzy picture here, but you can see at 2 weeks that we're already getting pretty complete root coverage. By 6 weeks, it's kind of interesting to note that we're getting a little retraction around 27 and 28. But by one year here, you can see that we already get a little bit of creeping attachment right here. So we have 100% root coverage at 1 year. Very pleased with this result. A procedure like this takes about 45 minutes, and patients are in very, very little discomfort. I want to address what's going on with the tissue appearance here. We used to think that because it doesn't have a nice keratinized look like with connective tissue grafts or free gingival grafts, that this tissue wasn't as strong. So I want to go over some cases at the end of this presentation to show you what that looks like upon reentry. So here's our before and after. So I think we can all agree that, you know, if you're a patient, you're pretty happy with this result. So one big question is, you know, for those of us who are traditionalists, how do acellular grafts compare to connective tissue grafts? So here's a side-by-side presentation I want to show you. In this situation, we have severe class 2 defects here. What's interesting to note is we have some pretty significant clinical furcations that you can see clinically, even before a flap is reflected. Radiographically, what I like to see here is that we don't have a whole lot of interproximal bone loss, so I do like that. It's good for our predictability. Upon flap reflection, what I've done here on number 14 is I've placed an alloderm graft for number 14, and for number 15 I've placed a conventional connective tissue graft. Here I've sutured the flap just in the same way that I showed you just in the last case. At 6 weeks, you can already see that we've got about 95% or greater root coverage on both teeth, and they also both look very similar. And then at 1 year, you can see, you know, the results have sustained themselves very well. The tissue is also very thick, but even on the connective tissue side versus the alloderm side, the tissues look the same, and yet they don't look completely keratinized. However, I'm satisfied with this result at 1 year. If it's still looking good at 1 year, then chances are it's going to continue to look fine. Here's a nice before and after photo showing our side-by-side alloderm graft versus connective tissue graft. So I talked about the alloderm, but what's new? There's always something new down the pipe with these products. We're always making advancements in how they handle. We're always playing with shorter hydration times, more predictability. And I want to share with you a particular product that I've been high on lately, which is perioderm. Similar to alloderm, it's also a human processed tissue. The only difference with perioderm is that it's not soaked in any antibiotics. So patients and doctors like that. You do get to store it at room temperature, so there's no need to refrigerate it. The biggest thing for me, or one of the biggest things for me, is that there's only a 3 to 5 minute hydration time versus 2 hydration periods with alloderm and some of the other grafts that are similar in this category. I'll show you that the thickness is also very uniform, and also at the end of this presentation, I'm also using it as a membrane for my guided bone regeneration procedures and ridge augmentations as well. So very neat stuff coming down the pipe. This is just a picture of the packaging so you can recognize what we're using. But here's a class 2 recession defect on number 30. This is where it gets really interesting with these acellular dermal grafts. Here we've got recession through the mucogingival junction with no keratinized or attached gingiva in this region at all. Upon flap reflection, you'll notice that we've got a pretty deep class 1 furcation on the facial aspect, and then we have a large dehiscence on that mesial root. This is what the perioderm looks like out of the package and after it's been hydrated for about 3 minutes. Once again, I'm still using the same suturing technique. It's just a simple sling suture over the facial surface. The thing that you'll immediately notice is that when we suture this, though, you can see how the perioderm absorbs the blood, which always makes me feel good that we don't, anytime we're putting essentially dead skin on an avascular root, when it absorbs blood, it just makes me feel better about how things are going. Once again, same suturing technique, suturing the vertical incisions with a continuous suture and securing the coronal part of it with a simple sling suture. This is our final result at 6 months. The cool thing about this is that isn't just the root coverage here, and it's not just the thickness that we got here, but look where the mucogingival junction has now repositioned itself. It's right here, and this is even with the flap design that I've decided to incorporate. You could get a similar result using a tunnel technique or an envelope technique. I have not found that the flap design has yielded any better or worse results. There's your before and your after. In the lower anterior region, I do want to point this out. I don't do this case to show you anything neat, except I do want to point out a word of caution. When you're working in the lower anterior region here, there's some pretty tight muscle pulls and from the frenum attachments, and some pretty tight musculature and plenty of elastic fibers that can cause all sorts of tension on your flap. So this is probably the only region where I would not suggest utilizing any vertical incisions. So for number 2425 here, we have 3 millimeters of recession that we're trying to cover. I also recommend doing a more full thickness flap because the tissue is already fairly thin. There's really no sense in trying to split it any further. Rather than do vertical incisions, I just recommend extending an envelope flap 1 to 2 teeth to the mesial and distal of the teeth that you're working on. Here we've sutured the perioderm around the necks of the teeth with just 5/0 vicryl again. And we come over the top with 5/0 vicryl sling sutures, just like before. One thing I forgot to show on the slide is I use a periolaser laser in diode mode to just loosen up some of the elastic fibers here and some of that frenum attachment, so we don't have so much tension on the flap. But at 12 weeks, you can actually see that scar line from that incision from the diode laser. Oh, sorry. Got a little ahead of myself there, but your before and after photo here, you've got pretty much complete root coverage of both number 24 and 25 using a very atraumatic flap design. So let's go on to some more serious business here. So far, we've just kind of showed you cases that you could do with a connective tissue graft. You can do them with alloderm, perioderm, whatever type of acellular dermal tissue you want to use. But I want to go over some of our more severe cases just so you can kind of get a feel for what we can accomplish. Here's a gentleman, an older gentleman on Coumadin. He presents with about 8 millimeters of recession on tooth number 11. The reason he came to see us is because he started getting some leakage on this class 5 composite, and as a result of that, his lip was rubbing that rough spot and had worn a sore in his tissue there. So we decided to go with a perioderm graft to correct this versus his own tissue, especially with him being on Coumadin. He obviously has some other dental problems as well. With our flap reflected, what I want to point out is this class 5 composite goes almost down the entire length of the root. So I had to go full thickness a little farther than I want, but once again, I think it's important to go full thickness to expose the top 3 to 4 millimeters of the alveolar crest. Here what we've done is we've removed that composite because once again, you're not going to get connective tissue to adhere to a composite material, so do your best to remove as much of that as possible. And here we've already deepithelialized our papilla. Here we've secured our perioderm. Right now, it probably wasn't obvious to everybody, but this is a huge advantage of an acellular dermal graft over a connective tissue graft, just simply because there are some people who have shallow palates to where you couldn't even harvest this depth of tissue. Here with the suturing, you can actually see where that ulcer was worn in by that class 5 composite. At 2 weeks, what's interesting to note is you can already see a nice little band of firm tissue being established there. By 6 weeks, you can actually see once again where the mucogingival junction is. It's not very thick, but it sure was a lot thicker than when we started. And then this is at 6 months instead of a year, but at 6 months you can tell we have a nice thick band of surrounding tissue. And compared to his initial presentation, the difference is night and day. So what about, so we've handled a single tooth, severe recession defect of 8 millimeters. What about ear-to-ear cases? What's an ear-to-ear case? An ear-to-ear case is, in my practice, I call it, ear-to-ear because it goes from molar to molar, whether it be second molar to second molar or first molar to first molar. So let's talk about how we do that. In this situation, this gentleman has severe recession on 6, 8, 9, 11. And I want to show you some of his side photos here. Sorry about some of the smudge on the mirrors, but you can see the furcation involvement on number 3. You can see the furcation involvement on number 14. So, traditionally, you would want to do, a connective tissue graft from the roof of the mouth. But once again, thanks to these newer materials, we were able to accomplish correcting this gentleman's defects with, one short visit. This case took about an hour and 20 minutes. So it's not a whole lot of chair time for me, and not a whole lot of chair time, probably more importantly, for him. Here we've got a similar flap design. The only difference is our vertical incisions are distal to the first molars here. Okay. From this angle, you can see the furcation involvement, the large dehiscences, and the extreme root exposure, especially on the first molars and the canines. See a ton of recession on the canine here, and once again that first molar. I've used the thick version of the perioderm, which is pretty much all I recommend for root coverage techniques. And we sutured it around all the canines, incisors, and the first molars. We advanced the tissue evenly and tension-free, utilizing our 5/0 vicryl sutures. This is what it looks like at 2 weeks. So I don't know how many of you have ever seen a connective tissue graft or autogenous graft at 2 weeks, but this compares very favorably to any autogenous graft that I've ever done. This is at 6 months. So you can already see that the papilla, even though we've reflected them off the tissue and off the bone, have already reestablished themselves. The tissue is nice and thick. We have a nice thick band with the mucogingival junction, well away from the gingival margins. And here's our nice before and after. If you want, we can even look at the first molars. You can tell that even though we didn't get 100% root coverage, the furcations have been reduced significantly. Big question among people who have done acellular dermal grafts before is, are vertical incisions a no-no? It used to be thought that the thought used to be that if you do vertical incisions with an acellular dermal graft, you're going to kill the blood supply and your tissue is going to slough and your graft is going to fail. And even though that may have been true, a decade ago, things are rapidly changing with some of these newer materials. I want to show you a case that it's a very common case in my practice, so it's not something that I just stumbled upon. I do this all the time. In this situation, we've got some recession on number 19, 20, and 22. We don't have hardly any keratinized tissue on number 22. But the biggest thing here that I want to point out is on 24, we have a high freedom attachment, and once again, very thin tissue, not keratinized and not attached. It's not uncommon in my practice, at least for this 24, 25 area, still do a free gingival graft. So what I've done here, to go over the treatment plan with you, we decided to do a perioderm graft on 19, 20, and 22 to cover the roots. But because of the class 3 recession on the number 24 area, I decided to go with the traditional free gingival graft. The reason I did this is because with class 3 recession defects, you're not going to get very predictable root coverage. So if I can't get very predictable root coverage, I'd rather at least go for a nice strong band of keratinized and attached gingiva. So here's our perioderm graft in place. And once again, notice the red color there because it absorbs the blood. Very nice. This is what a free gingival graft looks like compared to a perioderm graft. So if you're a patient, the question is, would you rather have some tissue taken out of your palate, or would you rather just have your doctor open up a package and have all the tissue that he wants? Here's the free gingival graft in place and over the 24-25 area. I've prepared my recipient site relatively aggressively. just to make sure that our graft wasn't moving. But you can see here that after we've sutured our perioderm graft, look how close our vertical incision is to the recipient bed. There's probably not 3 millimeters between the two. Here's another angle of it here. So you can see literally where our suture needle has gone through, in that 3 millimeter thin band between the two vertical incisions. Matter of fact, this incision isn't even, I don't even close that. I leave it wide open. So traditionally, this would be insanity. You would think that this would be a huge no-no, that you were going to cause extreme sloughing and necrosis of the tissue. But as you can see here at 2 weeks, it's not the case at all. At 2 weeks, you can see complete root coverage, plenty of thickness over the canine, which we didn't have before. And even our free gingival graft, which we just left exposed, has healed just fine. This is just another angle of the sutures prior to them being removed. And here in our final result, you can see that even though it doesn't have that keratinized appearance over the canine, we do have complete root coverage here. And here's that nice free gingival graft over number 24. And that has adequately addressed the frenum issue, as well as increasing the band of nice quality tissue there. So the biggest difference between the newer allografts, I've been showing you perioderm and some of its predecessors. The biggest difference, I think, is in the consistency. I put together a few slides of some of my older alloderm cases, and what I've noticed over the years is that every piece seems to be different. This one's thinner than all the other ones. This is thicker, and this one's kind of medium. This one's thicker again. So when you open the package on some of these, you'll notice the differences in consistency. The newer tissue banks, are better about becoming more consistent. So if I put our perioderm grafts up, they all look about the same sutured in. They're all nice and red. They absorb plenty of blood, so you feel good about blood supply getting into the area. And they're all consistent as far as the size, shape, and thickness, which I really like. But one question that I get from my restorative colleagues is, do these grafts hold up to trauma from occlusion? So anytime I think of trauma from occlusion, I always think about orthodontics, because I can't think of anything worse on a tooth than orthodontic forces. So here we've treated number 6, number 9, and 11 while this gentleman is in braces. And you can see afterwards, this is during the course of treatment, you can see that the recession has still completely healed and completely covered, even while his teeth are getting torqued with braces. But let's go over another orthodontic case. This lady came to us to treat number 6, 10, and 11. During the course of treatment, she mentioned that she wanted some aesthetic dentistry performed as well. She also decided to go into orthodontics. Right after we corrected her recession defects, she went into orthodontics. And even after braces and after her final restorations, this is 3 years later, you can see that number 6, 10, and 11 still have 100% root coverage. Aesthetically, we have better symmetry than before, but if you look at the surrounding tissue, it looks better than ever. So my next question, and I go through this learning process the same as you all out there. I always ask myself questions and look at cases to see where we're at clinically. So has anyone ever re-entered a perioderm graft to see what's underneath? My good friend Danny Milker was nice enough to give me this case, because once again, I don't just use all the brains I have. I use all the brains I can borrow. So here he's treated number 30 and 31. If you guys don't know Danny, he does a great course, a great presentation on biologic root shaping. But he does a lot of soft tissue grafting. So we're going to use number 30 and 31 as an example here. And what Danny's done is he's reflected a full thickness flap to expose the crest. He likes to use an envelope flap, whereas I like to drop vertical incisions in this area. But that's not the point. The point is he's put a perioderm graft over number 30. Let's put a traditional connective tissue graft over 31. Sutured it up, and this is his reentry. So you can tell that even over a connective tissue graft or the perioderm graft, in either case you get a nice band of fibrotic tissue there, nice dense connective tissue overlying those roots and bone. Just to show you another case, because we've been showing you a lot of canines lately. So in this situation here, he's treating number, I believe, 26 and 27 and 28. Mostly for number 27, especially with such a large deficiency in keratinized attached gingiva. There's his flap reflection. There's the perioderm graft in place, and that's it being sutured. Now, at his, I believe I can't remember if this is 6 months or a year, but it's at least 6 months. You can tell that we do have plenty of root coverage, which I think is gorgeous. Great job that he's done, but we always have a question about what is going on in this area here. It doesn't look keratinized. It may be attached, but we don't know. So what does it look like when we re-enter it? On my own patients, I rarely do re-entries, but Danny does them. And upon re-entry, you can see that we have a nice thick band of keratinized. I mean, I'm sorry, of a firm connective tissue underneath the loose mucosa. So it may be loose mucosa on the top, but it's nice and firm and dense underneath. The last case I want to show you guys, perioderm for GBR. I say perioderm for GBR because that's the material I'm using, but the fact of the matter is that acellular dermal grafts are not one-trick ponies. In addition to getting amazing root coverage on teeth, you can also use it to grow bone, using it as a membrane in your GBR or ridge augmentation procedures. It's an everyday occurrence for me, and I wanted to show you just one of our cases. This woman came to us. Number 10 was failing due to non-restorable recurrent caries on number 10. So the plan was to remove number 10 and graft the socket. She wanted implants to restore some missing teeth that have been missing for a while, but obviously you can see here we've got a significant sinus issue here, so we had to do a sinus graft to obtain the proper vertical height of bone there. So our treatment plan was to extract number 10, place a socket graft, sinus lift in the number 12 to 14 area, but clinically, as I'll show you, we also had to do a ridge augmentation in the number 11 to 13 area because, as mentioned, she had significant atrophy from years of being edentulous in that area. So my next slide, we got number 10. It's been atraumatically removed, no sacrifice of any labial plate there. But more importantly, look at how knife-edged our ridge is. It's very knife-edged. No bone for implants. So what we decided to do is a simultaneous sinus graft in this area here, as well as a ridge augmentation in this area. Here's our lateral window being made with a round burr. Here we've just simply impacted the buccal wall, and which becomes the new floor. For my sinus grafts, I always place a piece of collar tape in the most superior part of the graft. I like to use a demineralized bone putty as my top layer. I like to put our bone grafts in layers when it comes to the sinus. Then here, my third and final layer, I use a combination of bio-os as well as mineralized cortical bone from MTF is the product that I use. When it comes to the ridge augmentation part, we make cortical perforations with a small round burr. And where it gets really interesting is, we use the same mix of bone that I used in the sinus to place it on the lateral wall here to augment the bone. But in accordance with traditional bone grafting techniques, we have to keep the epithelium out. We have to stabilize and submerge our graft. So I put a perioderm graft. In this situation, when I use perioderm as a membrane, I use the thin version. I place it over the graft, and I make sure that I get nice primary closure. One thing that I may have failed to mention is in all these grafts, when you're using acellular dermal tissue, you have to get primary closure. It's imperative that you do that. At 6 months, you can see that our sinus augmentation worked just fine. We have plenty of vertical height of bone, which at this point, predictably as well, our socket graft worked as anticipated. At this point, we're ready to do our implants, and I want to show you the re-entry here because it's quite astonishing to me, what perioderm and other bone grafting materials can do for us these days. Here's just a simple stent that I use to help with our spacing. When we reflect the tissue, you can see how wide the bone is after just one procedure. Once we've cleaned it up a little bit, you can see, once we've made our initial osteotomies, these are all 2mm holes. You can see how wide the ridge is. There's our initial pin placements here. And I won't bore you with the rest of it, but the end of the case was the placement of 4 ankylosing implants, oriented, fairly well. I was pretty happy with the position and angulation of them. But anyway, just another example of another use for an acellular dermal graft. So the question that I want to leave you here with, whether you're a restorative dentist or a periodontist, whether you're into pink aesthetics or white aesthetics, the big question is, which would you rather restore? This case on the left or this case after we're done? And if you're a patient, could you imagine how much easier it is to say yes to more comprehensive dentistry when you can see that you don't have to live with these permanent deformations here. You can actually have an ideal smile. And when patients can have hope and know that they can have an ideal smile, they're much more willing to say yes. The conclusions of today, just to kind of bring home a few points. Once again, I don't suggest that we eliminate the palate as a graft source. I think it's got its place. Remember, I showed you the correction of the amalgam tattoo earlier. But I think we have other things that we can offer patients. Acellular dermal grafts, because of their advancements and how easy they are to use. It's not near as complicated or technique sensitive as we once thought. They do have to be completely submerged. Please don't forget this. It's not like a connective tissue graft. You have to completely submerge it. And advancements in materials are making them faster and easier to use. So I showed you my particular flap design, which is nothing fancy at all. It's 2 vertical incisions and a periosteal release. It's a very simple suture technique. So you don't have to be a hand god anymore, to get these materials to work. They're just so predictable now, and patients and doctors are really, seeing the advantages. But not only are they great for root coverage, keep in mind what we're looking at now is that they're great for using as a membrane. So we're starting to see more uses for them in all my bone grafting and ridge augmentation techniques. So it's got its place in implant dentistry as well. With that, I do want to invite you guys to email me with any questions. I'm going to do a question and answer session real quick. But please email me anytime with any questions. On our website, we also have videos of other surgeries that you may be interested in as well. Dental XP has been nice enough to invite me on, so I'd like to thank them for hosting this webinar. Thank you all for attending. I also would like to thank Dentsply Tulsa Dental Specialties for sponsoring this presentation today. I do, just for those who are interested, I do have a technique video on perioderm that's going to be available on my expert page on Dental XP. So be on the lookout for it if it's not up already.